Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health. Hello, everybody, and welcome to another edition of Doc Talk. My name is Mark Houston, and joining me today is Dr. Nicholas Hopson, who is a urologic surgeon at Monument Health. Now, before I get started, I want to try this. I want to test something out on you to see how close I get to this, okay? Willkommen till Schule. Did any of that make sense to you?
Welcome to Schule.
The show.
Oh,
Was
yeah.
I close? You speak Danish and Spanish.
Yeah, that sounded more German.
Oh,
to
great.
me, but
See? I knew I would screw it up anyway, but I thought I would at least give it the attempt.
I was impressed.
So what with those two languages specifically, what drew you to those?
Well, Spanish I took in high school, and,
Okay.
and then I ended up marrying a woman from Guatemala.
Oh, okay.
So we visit Guatemala frequently, her family visits. I've done a lot of time in the hospital, volunteer work down there.
Yeah.
So I've really developed my Spanish, and I did my residency in San Antonio, so I used it a lot there.
Of course.
And then I served an LDS mission, church mission.
Oh, sure.
In Denmark.
How long were you there?
2 years.
Okay.
And so part of that is language training. So
It seems to be a ridiculously hard language to learn, is it? I mean, most people know Spanish around here.
Yeah,
it seems to be, it's our second language really anymore in the United States. But
well, because I was so
Danish,
immersed in it for 2 straight years, I would say it's been easier to learn Danish than Spanish.
Really?
But the accent in Danish is what throws a lot of people off because you have to speak in your throat kind of.
Well, and looking at the word SHOW, I think LT or LET, ET, yeah. And then you say it as an L sound at the end almost.
It's show it. Actually, that would
all right. Well, then I'm mad at Google is what I'm mad at for trying to teach that to me. Well, you, like we said, you're a urologic surgeon from Washington State,
yes,
correct? So
originally, yeah.
You've only been here since you said last September.
Yeah.
So what brought you to the area here, doctor?
Well, I wanted to get out. I got out of the Army a year ago, and all my family settled in the Mountain West.
Okay.
And that's where I went to school in Utah, and from undergraduate. And so I just looked in the region and looked at jobs, and this one came up. And I never heard of the Black Hills. I knew of Mount Rushmore, but knew very little of South Dakota. And when I saw the description of the area with mountains and skiing and hiking and all year-round activities and no more heat and humidity, it really piqued my interest. And then I met with the group and, the hospital, the urology group that was already here. I just was really impressed by everything that Monument and the urology group had to offer, and it just fit really well.
Do you have like a medical background in your family? Do you have other family?
No, I mean,
really?
there's some nurses
Sure.
and whatnot, but I was kind of the first physician.
So what drew you into this profession specifically, doctor?
When I was a kid, I had allergies really bad, actually. And then, so I spent a lot of time in the doctor's office getting allergy shots and whatnot. They were trying to figure out for a long time what was wrong with me. So then I got allergy shots for 5 years. You go in once a week or once a month. And I just really liked the environment. I loved the caring nurses. And I found it really pleasant. And then they helped me. And so I got better. And so that is kind of what got me down the road of being interested in medicine. Excellent.
Well, what we want to talk about here, since you are a urologic surgeon, especially for men, I think this really has become seemingly a hot topic over the years. And maybe we can get into it a little bit later here in the podcast. But it seems like this is something that it's happening to men younger and younger now. And that's why I think we want to talk about the importance of prostate cancer screening on this podcast. Are you finding that to be true? It seems like I've read a lot of, I don't know if they're clickbaity kind of headlines about this. It seems like this is happening younger to guys.
Yeah, I mean, I think as people are becoming more and more aware of it, we're testing earlier in most cases. So I think we're catching it earlier in a lot of men. And also awareness is growing about it. So I don't know that it's necessarily we're seeing it in younger and younger men.
Okay.
It's just, I think the awareness is out there more, so more people are coming in to be tested. And I think our guidelines are getting better and better. They just updated them recently with recommendations for when to screen and whatnot. So, if somebody in your family, like your father or brothers, has had prostate cancer, then we're recommending we screen younger, as early as age 40.
Because it always used to kind of be in that 50-year-old range,
Yeah.
correct?
And it still is 50
Sure.
to 55 if you're of average risk. But if you're in increased risk because of family members or even race, then we tend to screen down into the 40s.
Okay.
So so the more we screen, the more we find.
Right. And the screening is something I think that's kind of interesting with this now too, because of course everybody knows, all guys know when you are screened for prostate cancer what the process is.
Yeah.
Is that happening as much anymore though, or are other forms of testing coming along to where that's not as necessary?
Yeah. So we've had the PSA blood test for a long time, as well as everyone loves the rectal exams.
Right.
That's always kind of been a staple of it for it. And about 10 years ago, there was a U.S. task force that came out with physicians from different specialties, and they looked at the literature, and they felt that maybe screening wasn't necessary or we shouldn't push it as much. But with that, we kind of saw a rise in people being diagnosed with prostate cancer at more aggressive levels or more advanced degrees, and so I think we've kind of come to more of a happy medium there, because the earlier consensus with that task force was that we were over-treating and not really seeing a benefit in the numbers of people who are surviving from prostate cancer. So now there's a really big push, especially in the urologic community, to counsel with the patients, like make it a shared decision whether or not a patient wants to be screened for prostate cancer, rather than just making it an automatic screening mechanism. But PSA is still, the PSA blood test is still the go-to in most settings. We've had other blood markers that we've found that could be beneficial, but they haven't become widespread. The PSA test is really inexpensive, and it's available everywhere.
Yeah, it seems like you can almost get that when you just go in for your yearly check. It's something they can check.
And that's something that actually the guidelines changed. That used to be they recommended getting your PSA checked every 2 years if you're at average risk. And now I just saw that it's been changed to every 2 to 4 years.
Okay.
So, but because most men get their labs checked once a year, that just kind of gets thrown on there.
I got it. Okay, let's talk a little bit about the prostate itself and its function and why there's seems to be problems with it.
Yeah.
All right. So what is your prostate, and what is the purpose?
Yeah, so I think it's something that most people know exists, but some people think maybe men and women have it, and most people don't really know what it does, just that it causes problems for men. It's actually a pretty important little gland. It's a gland because it secretes fluid, so it's a sexual gland. But it's also part of the urinary tract, because when men ejaculate, it comes out the urethra just like urine does, and so it's tucked up right underneath the bladder, and it kind of is shaped like, I like to describe it like a donut, because it hugs the urethra that way and up against the bladder. And so when a man ejaculates, it secretes the seminal fluid into the urethra, along with the seminal vesicles, which are also right in that same area, and the sperm that come from the vas deferens. So they all kind of coalesce right there, right at the base, right underneath the bladder, kind of, into the urethra. And so the prostate produces some of the seminal fluid. And also, on the outside of the prostate is very important for sexual function, because that's where the main nerves are that control your erections and your sexual function. So that's why one of the concerns with treatment of the prostate for different conditions can lead to erectile dysfunction.
So when it comes to the cancer, I mean, what everybody really understands about the prostate is the cancer that can be a part of it. Why is it an organ that's so affected by cancer? It seems to be one that is common. Is it a common cancer, really? Then?
Yeah, it's either the first or second most commonly diagnosed cancer in men, and first or second in number of deaths that it causes. Right. And so I don't know if I have a good answer for why cancer occurs there so much versus other places like the seminal vesicles, which are also part of that little system. We don't really see cancer developing in those structures. It's just really in the prostate. But it is a very common form of cancer, and so that's why it's easy to screen for. But one thing that maybe I can say to why it happens there so commonly is the prostate continues to grow as men age, and it's part of the reason that it grows is the way the testosterone in men's body affects the prostate. It needs testosterone to function, to performance function, and that testosterone also causes it to grow as men age, which leads to problems with urination,
right?
Which we can talk about another time.
Yes, absolutely. Well, I know. One of the other topics that we do want to discuss is this benign prostatic hyperplasia.
Yeah.
Right. Which is just an enlarged prostate. Prostate, correct? Yeah. And that's not really super serious, I don't believe. I mean, not like getting a cancer, obviously. But when I think a lot of men too maybe have heard or understand that this is also kind of a It's not super aggressive as a cancer, is it? It seems to be rather slow growing. Is that right?
Yeah, the vast majority of the time, it's slow growing. In fact, I heard a patient describe it today in a way I had never really heard it described. Since there's different degrees of prostate cancer, essentially, and he described it as snail, turtle, and rabbit.
Okay. Well, that makes sense, I guess. Yeah.
Yeah, and I like that. The majority of men will have if they're diagnosed with prostate cancer, will have like the slow growing type of prostate cancer, and a small subset of men will have more aggressive kind of cancer that spreads and metastasizes more rapidly. And we do see men who show up with metastatic prostate cancer spread to the bones and different parts of the body. And that's what we're trying to prevent because that's more difficult to treat.
Yeah.
But the vast majority of men have low-risk prostate cancer or intermediate risk, which means low risk or intermediate risk for spreading to other parts of the body. And so the low risk is generally what we quite often just watch, and we call that active surveillance. And so that's something that's become a little bit more of a newer development in the last 20 years or so. Maybe back into the 90s, very few people would just sit and watch their prostate cancer. They pretty much gave radiation or took out the prostate in any man who had any form of prostate cancer.
Yeah. Is that normally the treatments? What are the treatments for cancer for this?
Yeah,
generally.
So if you're someone who's recently diagnosed with low-risk prostate cancer, your options are generally active surveillance, is where we would just watch it with a PSA every 6 months or so, and then repeat the biopsy in 1 to 2 years after the first biopsy. That's how we diagnose prostate cancer, with the prostate biopsy. You can also treat it with some newer treatments that are called focal therapies, and those are meant to be less invasive and not treat the whole prostate, but just the areas where the prostate cancer was found. And those are promising. They're not they're not the mainstream treatments quite yet. They're not offered everywhere. Like here in Rapid City, we don't have those available, just because they haven't been around long enough to have proven the test of time and show that they have long-term results. But other treatments that are the mainstay are surgery, where we remove the prostate, and radiation. And there's different forms of radiation, like brachytherapy, which is implanting radio isotopic seeds into the prostate, and then external beam radiation, and so traditional forms of radiation. But then intermediate and the higher end of intermediate and true high risk prostate cancer is usually best treated with either surgery or radiation or both in some instances.
So a prostate removal is like the last resort. That's what I'm assuming you don't want, right?
Yeah.
I mean, what's quality of life like for having it removed?
So, I mean, there's varying degrees of what people experience after prostatectomy, and it also depends on what their symptoms were before. So the main side effects of either radiation or a prostatectomy generally are erectile dysfunction. If you don't have it before treatment, there's a very high likelihood that you will have it. If you did have it before, but it still worked with medications, then it'll probably be a little bit worse after those treatments. After surgery, you may experience incontinence, or you almost certainly will experience incontinence right after surgery. That's where you leak on yourself.
Right.
And that's not pleasant, but the vast majority of men will regain their continence.
Okay.
I usually see patients at the 1 month mark after surgery, and I recently had a patient who had actually 2 patients that I just saw, they had regained full continence within that first month of surgery. So they tend to be a little bit more fit and healthier patients to start with, though. So that's very helpful for that. And then radiation quite often will have side effects of irritation of the bladder.
Yeah.
So they may feel like they need to pee more often or have some more difficulties controlling the urge when it comes.
So what can you do to make sure you don't outside of genetics? Are there steps you can take
to prevent prostate cancer?
Yeah, I mean, or at least to give yourself the best possible chance of never getting it.
Yeah, so that's a really good question, and unfortunately, we don't have a great answer for that.
Really?
yet.
Yeah.
You know, we found that genetics and race and age are the 3 biggest risk factors for prostate cancer.
Okay.
So, you know, if you're the reason why we screen for prostate cancer essentially from the 50s to about age 70 is because that's when most people will be diagnosed with prostate cancer.
Right.
African American males are at highest risk for prostate cancer, and then, you know, quite often we'll see men who have a father and brothers who have prostate cancer. So you can't really change those factors.
Right.
There have been some vitamins that have been studied and supplements that maybe have shown some benefit, but nothing really that is something that we can hang our hats on.
Yeah.
And so right now, it's just I would recommend screening so that you can know early on.
Well, with the going back a little bit to those PSA tests, was there a time though when those weren't quite as reliable as they are now? It seems like there was, I don't know, 10 years ago maybe, there seemed to be a lot of false positives that came around with that blood test. Has it always been as accurate as it is now, or has it been kind of a learning curve with it too, I suppose?
Yeah, I mean, the tests certainly, I believe, have gotten more accurate. They're more sensitive now, and we can detect PSA at lower levels than we used to be able to. So that's really helpful, like, after we've treated somebody for prostate cancer. But the levels of your PSA is pretty reliable. I guess where we get false positives is what is a normal PSA for somebody. It does change as you age. Higher your PSA tends to rise as you age. But when they were doing the studies of what is normal versus what's not, they kind of just arbitrarily chose 4.
Oh, I see.
4 is the cutoff. And so just because you have a PSA of 4.5 doesn't mean you have prostate cancer.
Well, because that'd be like an enlarged prostate too? I mean, could those play into that as well?
there's a lot of factors that can cause it to be elevated, such as you already have an enlarged prostate, that can cause it to be elevated, or urinary tract infections, recent sexual activity. So we usually advise people to hold off from sexual activity for a few days, 3 or 4 days before having their blood drawn for PSA. Quite often we see people with enlarged prostates who don't empty their bladders very well, who have an elevated PSA because of all the pressure built up in their bladder. Pushing on. I saw a patient once who he'd gone through, I think, 3 prostate biopsies for an elevated PSA, and I first time I saw him, I checked his bladder, and he had way too much urine in his bladder.
Just was holding it too long and not going.
And so he didn't know it because it had been a gradual process.
Yeah.
And once we treated his enlarged prostate, and he was able to empty his bladder, his PSA dropped to a very small number.
Wow.
And so, there's a lot of factors that can cause your PSA to be elevated. I always counsel patients that the prostate cancer is one of the things.
Yeah.
So we need to we need to find out what's causing it.
Well, this was ridiculously interesting. I mean, from being a guy and from hearing this, as I've gotten older too, the steps you have to take. And I didn't realize it. I always kind of had the assumption that it's one of those throwaway organs, right? That's it's there, but why? Like your appendix. Do we need it? Yes, apparently we do need the prostate. Oh boy. Do you ever see a time down the road where do you think technology will improve enough to maybe we can really get a handle on this to prevent it maybe down the road, just cancer in general in the prostate?
Yes, I think we're making great improvements in our focal therapies, such as HIFU and cryotherapy. These are treatments that are starting to take off more, and even radiation treatment such as CyberKnife, which was I think used more initially for brain cancers, but it's kind of I've seen some good results in prostate cancer. So I think we're getting there. It's not taking out the prostate isn't as big a deal as it used to be. Quite often we're sending patients home the same day.
Oh wow! Now can parts of the prostate be removed too? Or is it all or nothing?
It's kind of an all or nothing thing. To just treat parts of it, it would have to be one of those focal therapies.
Sure.
But as far as surgery goes, we do it laparoscopically with the Da Vinci robot.
Mm-hmm.
So men are leaving the hospital with 4 or 5 incisions.
Wow.
Small ones. And if they're not going home the same day, most are going home the next day.
Okay.
And we are at Monument. We're getting the single port robot, which would mean instead of having 4 or 5 incisions in their abdomen, they have one about 2-inch incision, and we're able to do everything through that one port.
What I'm hearing specifically for robotics coming out of Monument is so exciting and encouraging. What you guys are able to do now to get people in one day in some instances on these surgeries that used to be, you're in the hospital a couple nights, if not a week, sometimes, right?
Yeah.
So that has to be exciting for you guys too.
Yeah, and we have multiple members of our urology group who perform that surgery, and Dr. Santa Cruz, I think he just surpassed over 1,500 robotic cases.
That's amazing.
Since he's been at Monument. So
excellent.
We're doing great things, I think.
Well, this was a lot of fun to talk to you, Dr. Hopson, and I think it's just reassuring because this probably is one of the scarier cancers that men think about, I'm sure, and it's just reassuring to know that. It's super treatable if it's caught in time, generally.
Yeah, lots of options for
treatment.
Yeah,
a lot of options. That's the key, I think, right there. Dr. Nicholas Hopson, urologic surgeon at Monument Health, thank you very much for coming in and talking about this. I appreciate it.
Thanks for having me.
You bet.